Good afternoon. Thanks for joining us. My name is May Thamer. I'm the head of a project funded by PCORI to disseminate findings from several large, recently completed research studies that focused on dialysis care. So welcome to our webinar presentation today for ESRD network staff that's entitled Improving Patient Quality of Life and Caregiver Burden by Peer-Led Mentoring Program for Patients with CKD and their caregivers. Let me introduce today's speaker, Dr. Nasrollah Ghahramani from Penn State College of Medicine in Hershey, Pennsylvania. Dr. Ghahramani grew up outside Philadelphia, but he returned to Iran for medical school with the intention of living there for good. He finished his residency and his fellowship in Iran, and after being allowed to leave the country, he obtained a research fellowship in nephrology at Yale. Later, he did an internship at Vanderbilt, and he's currently the professor of medicine and public health sciences. He's chief of nephrology, and he's the medical director of the kidney transplant program at Penn State. For attending this webinar, one continuing education credit is available to all nurse and social work attendees who pre-registered, who attend today's event, including filling out the evaluation form at the end. However, for those of you who are joining only by phone, please send your phone number to Heather at hcecil@nw5.esrd.net. Again, that's hcecil@nw5.esrd.net so that she can verify your attendance for your continuing ed credit. These will be mailed to each attendee based on the email address that you provided during registration within 1 month of this event. So finally, please post any questions that you have during the presentation using the Q&A icon that you can see at the bottom of your screen, and we'll try to answer as many questions as possible at the end of the presentation. Now I'm happy to turn it over to Dr. Ghahramani. Thank you.
Thank you very much, Dr. Thamer, for the introduction, and good afternoon, everyone. I appreciate the opportunity to present an overview of the work we've been doing on peer mentoring among patients with CKD and their caregiver. This research was funded by a generous grant from the Patient-Centered Outcomes Research Institute, this is an overview. These are the general topics and themes that I'll be discussing over the next 45 minutes. So let's start with an overview of the information needs of patients with CKD and their caregivers. I don't think I need to convince anyone on the call that CKD and end-stage renal disease are significant global health problems. In the U.S., the incidence is more than 120,000, and the prevalence is over 720,000. CKD is associated with significant morbidity, mortality, and cost, and it's also associated with significant negative effect on quality of life, which in turn is correlated with mortality. If you look at the trajectory for patients with chronic kidney disease, you realize that there are multiple time points when patients and their caregivers need to make decisions about treatment. There are certain treatments that are perceived to be more desirable, but they're underutilized. For example, home modalities are known to be associated with improved quality of life and lower cost. But when you look at the number of patients on home modalities versus in-center hemodialysis in the United States, the proportion of patients on home modalities has remained fairly flat at approximately 12%. And regardless of the modality, the optimal situation is planned initiation with a permanent access, so planned initiation of dialysis with a permanent access. However, unfortunately, 50% of patients actually crash into dialysis with a temporary catheter, and by default, they end up on in-center hemodialysis. Now, by the same token, transplant is associated with improved survival, quality of life, and lower long-term costs. And of the options for transplant, preemptive transplant is associated with better outcome. However, most transplant patients receive deceased donor transplant after variable periods of dialysis. Now, there are many factors that influence the treatment decisions among patients with chronic kidney disease, and the traditional focus has been systems-related factors and provider-related factors. However, we know that there are significant patient-related factors that we sometimes fail to acknowledge. For example, taking a look at factors that patients consider when making decisions, transplant might be considered when improved quality of life is a major factor, while dialysis might be preferred by a patient who wishes to avoid the uncertainty that's related to the trauma of rejection and the risks of immune suppression. The relative predictability of dialysis, or the routine of dialysis, might actually be attractive for some patients. And also, while autonomy and control are important factors in choosing home modalities, some might actually prefer in-center dialysis because of a planned schedule and preference in having others take care of them and the social interactions that are associated with in-center dialysis. So often, patients make treatment decisions without being engaged in the decision, and in reality, a decision is made for them rather than by them. When that happens, they're less likely to be satisfied with the choice. That leads to poor quality of life. In order for patients to be engaged, they need information and education. So with that, let's take a look at the first polling question. Good. So, excellent. Yeah, so I think all of us agree that other than encouraging patients to get a pet, all the other options are actually the correct options for providing patients with information. All right. So not only does information help patients make a decision based on their key preferences, information alleviates anxiety, it facilitates awareness, improves adherence, which will lead to improved overall care. Something that we might often overlook is the fact that seeking information is actually a common coping strategy that we all use in various settings. Now, for patients with chronic kidney disease, we know that information is presented late with no time for engagement and no time for informed decision-making, or little time for informed decision-making. And furthermore, information often overlooks the needs of the patients. And when we look at research priorities, the researchers' traditional focus has been clinical outcomes, while patients' focus of research priorities, and this has been shown in studies of patient priorities, quality of life, satisfaction with care, and caregiver burden are priorities for patients. Quite frequently, the patients don't receive the sufficient information to understand the diagnosis, to cope with uncertainty and to integrate the treatment into their daily routine. Now, switching gears, let's talk about peer mentoring in chronic kidney disease. But before doing that, how about if we go to the next polling question? Good, excellent. So essentially all of the responses are correct except for the fact that ideally peer mentors should not be making decisions in the patient's place. They might facilitate the decision-making process, but they shouldn't be the ones who make the decision in the patient's place. Okay. Overall, peer mentoring is an effective strategy for active patient engagement. Peers with the same chronic disease are in a unique position to share knowledge and experience, and peer mentoring is thought to be successful mainly because it's non-hierarchical and there's a reciprocal relationship. Really do not have much information about the role and impact of trained mentors on the care of patients with CKD, and that's why we undertook this study. In most chronic conditions, particularly in chronic kidney disease and in end-stage kidney disease, caregivers play a very fundamental role. So it should not come as a surprise that significant caregiver burden might result from providing care to patients with chronic kidney disease and end-stage renal disease. And it has been proposed that peer mentoring may lead to improvement in caregiver burden. And with that, our next polling question. Why is peer mentoring useful for dialysis patients? You can select as many as you wish. All right, good. So essentially all of the responses are correct. Now with that rather lengthy introduction, let's now talk about the Patient Family Partner Program, which is a structured peer mentoring program for patients with chronic kidney disease and their caregivers, which has been developed by the Kidney Foundation of Central Pennsylvania. So this is a comprehensive program that's been operational by the Kidney Foundation of Central Pennsylvania for the past 15 years. So in this model, well-adjusted patients and caregivers are trained through a 16-hour structured program to become peer mentors to newly diagnosed patients with CKD and their caregivers. After being trained, the mentor candidates are designated as certified partners. They regularly provide and receive feedback and are required to attend one quarterly refresher per year. The actual mentorship consists of weekly phone contact and monthly in-person meetings, and the program coordinator oversees the program very closely. to the next polling question. All right, great. There is there's really insufficient information about the role of peer-led mentoring in CKD and ESRD patients as related to improved survival. There is some information about self-efficacy, increased knowledge, perception of social support, and increased hemodialysis social support. Not that it will not lead to improved survival, but we just don't have sufficient data to note that. Now, let me share a story. The story of a highly educated nurse, Peggy. She's married to a prominent cardiothoracic surgeon. She happens to have polycystic kidney disease. She develops end-stage renal disease and is overwhelmed, distressed, and has difficulty deciding between hemodialysis and peritoneal dialysis. She finally decides on peritoneal dialysis, but all throughout, she thinks to herself, if I, with my background, have faced so many challenges, how are other, less informed, newly diagnosed patients dealing with the challenges? The thoughtful person that she meets with a transplant coordinator and a renal social worker, and they brainstorm and come up with the idea of a peer mentoring program. I had the privilege of meeting Peggy at a fundraiser dinner for the Kidney Foundation of Central Pennsylvania. We talked about the peer mentoring program. She asked if I would be willing to serve as the medical director of the program. I agreed. We started working on the curriculum and the textbook, and the revised program was delivered to patients and caregivers. Now, a few words about patient-centered research. In the traditional model of research, you have Professor Genius working at the prestigious university, collaborating with Professor Weiss and Professor Eager. They find collaborators in various other universities. They collaborate with Professor Distinguished at Great University and Professor Smart at Premier University. They come up with a proposal which they submit to a funding agency. The group of reviewers at the funding agency review the proposal. They like it. They fund Professor Genius and his collaborators to do the study. The study is completed. Professor Genius presents the study at various national meetings, and people will give him standing ovation and realize that he's a real genius. Everybody's happy, but look at Charlie in this corner. He's the one who's actually paying for the research and is supposed to benefit from the findings of the research, but he's really nowhere to be found in this scheme. So keeping that in mind, and as a paradigm shift, PCORI, Patient-Centered Outcomes Research Institute, was mandated as part of the Affordable Care Act to essentially do research differently, with patients involved in all stages of research. In other words, going back to our model, Charlie is now at the center of the process, where he actually should be. And then finally, let's talk about our research. This is our hypothetical framework for the research. We believe that the patients with chronic kidney disease and their caregivers have information needs, and if we involve them in an educational mentoring program, it's likely that there will be more engagement in care. For patients, there will be improved quality of life. For caregivers, there will be decreased caregiver burden, and then that will translate into improved clinical outcome. Although we did not, in this study, we didn't look at the clinical outcomes. Our specific aims were to look at the quality of life of the patients, burden of the caregivers, and engagement in care for the patients. So we proposed a randomized control trial to test the effectiveness of peer mentoring in comparison to usual care on patients with chronic care on patient quality of life, patient engagement, and caregiver burden. For several reasons, we felt that the Patient Family Partner Program is an ideal PCORI project. It was envisioned and designed by a kidney transplant recipient who was a nurse in collaboration with healthcare providers. The design of the program was based on input from stakeholders. The board of the Kidney Foundation of Central Pennsylvania was of the ideal composition to serve as the community advisory board as required by PCORI. I, as the principal investigator, had an established relationship with the Patient Family Partner Program and the Kidney Foundation of Central Pennsylvania. We proposed the study, and we're very happy to receive funding from PCORI to conduct it. Now, in regards to our outcomes, everyone's familiar with the quality of life survey, so I won't go into detail in that regard. But our other instruments included the patient activation measure, which is a 13-item questionnaire that's a valid and reliable instrument to measure activation, and the Zaret Burden Interview, which is a 22-item instrument which measures caregiver burden. The study included patients and caregivers. On this slide, you see the patient participants. So the patients are those with CKD stage 4 and 5. They completed the quality of life survey and the patient activation measure at baseline, and then they were randomly assigned to either the control group, 6 months of face-to-face mentoring, or 6 months of online peer mentoring. And they completed the survey instrument at 12 months and at 18 months. The process was similar for the caregivers, with the exception that they completed the Zaret Burden Interview instrument. We compared the mean scores at baseline with mean scores at 12 months and 18 months in each group, and used the linear mixed effects model to estimate the slope of change of the scores. When we look at the results for the quality of life, the baseline score and demographic characteristics were not statistically different among the 3 groups. These are the results in tabular form. For those who like tables with numbers, you see that the only improvement among the face-to-face group, that's the red column, was in symptoms, problems, kidney disease score, and the SF-12 mental composite summary. However, as you note, they're not sustained at 18 months, so there is an improvement at 12 months, but not sustained into the 18 months. However, if you look at the green column, the online peer mentoring column, there were improvements in all the domains, and they were all sustained at 18 months. Now, there was a bit of a delay in the effects of kidney disease subscale. We saw it at 18 months. We didn't really see a significant difference at 12 months. For those who prefer figures, this is the exact same concept in figure format. and the stars indicate change from baseline, so statistically significant change from baseline. Again, the red is the face-to-face, and the green is the online, and you see that you see the same concept essentially. And here, broken down by the intervention. This is the control group. You see that the bars are pretty flat in each of the subscales. In face-to-face, change at 12 months for symptoms and problems of kidney disease, and at 12 months for the mental composite summary. Again, the online is associated with significant change that's sustained at 18 months in all of the subscales. Now, moving on to our other specific aim, which is the active patient engagement. Again, the baseline patient activation measure score and the demographic characteristics were statistically similar among the three groups. The table shows significant and sustained change in the online peer mentoring group, and no change in the face-to-face or the textbook group. And again, this is the same thing in figure format. The online sustained improvement in PAM score, and no change in the face-to-face peer mentoring or the textbook. For caregivers, also the baseline desired burden, interview score, and the demographic characteristics were similar among the three groups. In tabular format, we saw that there was change among the face-to-face peer mentoring as well as the online peer mentoring. So this is unadjusted. Again, in figure format, significant decrease in caregiver burden among the face-to-face and also among the online peer mentoring. Now, when we looked at the adjusted changes, adjusted for demographic variables, we see that desired burden interview score showed a sustained and significant decrease only in the online peer mentoring group. That's the green, with the slope estimate of -3.4. So when we did the adjustment, we realized that face-to-face is not really significant. Does not lead to significant change in ZBI score. So in summary, among patients with chronic kidney disease, online peer mentoring is associated with sustained improvement in subscales of the kidney disease quality of life survey. There's sustained improvement in patient activation measure at 12 and 18 months. Among caregivers of patients with CKD, online peer mentoring is associated with significant improvement in caregiver burden score. Our study has certain limitations. These are some of them. I'm sure there are others. These are the ones that when we were discussing among our colleagues, we realized that number one, it's the fact that the number one limitation is the fact that there was a requirement for computer and internet access. So it is biased. The study is biased towards a group of individuals who have computer and internet access. It was limited to the English language. Geographically, our study was in central Pennsylvania, a large geographic area, but still limited to one region in the country. And another limitation was the fact that we did not record the frequency of online interactions. The reason I bring this up is the fact that we are all surprised that online was associated with so much better outcomes than face-to-face. Intuitively, we would have thought it would have been different, that the face-to-face would have been at least equal. One possible explanation is that the mentees would be more comfortable posting online and receiving a response because of the perception of less time burden for the mentor. This is in contrast to having to meet with the mentor, which would be a time constraint for the mentee and also for the mentor. If we had data to number of online interactions, the frequency of online interactions, and we would somehow do subgroup analysis of those who actually had more frequent online interactions, had improved outcomes. That might have been in support of the explanation that I just mentioned. So I actually have thousands of thanks to hundreds of individuals. This is just a list of some of them, all of the patients and their caregivers. Tara and Tabitha, our research coordinator and our project coordinator at the time, Joan, Line, Robin Asik, Christy Washinger, the Kidney Foundation of Central Pennsylvania, Executive Director Phyllis Hicks, our research team, Dr. Krishnowski, Dr. Lingridge, Dr. Shimana, Dr. Chinchilli, and Charlie Coltman, who developed the web-based platform. So this is the governance of our team, and by presenting this, and now I'm sure that I haven't missed thanking all the individuals, although names are not there, but this was our research team, the project managed team, which consisted of the research coordinator, the program coordinator at the Kidney Foundation of Central Pennsylvania and Patient Family Partner Program, the designer of the online platform, Charlie, our patient representative, Michelle, our provider representative, Robin, the patient and caregiver advisory group and a provider advisory group, and then the board of directors of the Kidney Foundation of Central Pennsylvania served as the community advisory board. So this research was in close collaboration of us at Penn State with the Kidney Foundation of Central Pennsylvania. We could not have done the research without the valuable help of everyone at the Kidney Foundation. Unfortunately, Peggy is not with us to see her visionary work gaining the national attention that it deserves. So I dedicate the work and this presentation as a special tribute to Peggy Jane Pierce, who pioneered this work. And with that, let's do the last polling question. All right, so 13 have face-to-face peer mentoring, 5 online peer mentoring, 10 have informal patient support groups, 4 counselor-led groups, 2 yoga, 5 meditation, and 12 other programs. Wonderful. Thank you so much for participating and for answering the polling questions. So I think we'll open up now to questions.
Dr. Ghahramani, do you see there are already some questions?
Yes.
Can you open those up and address them?
Okay, yes. One of the questions is, could the anonymous nature of online interactions be a reason for their preference? So since they weren't really anonymous, because the mentor-mentee were paired, and think of this platform as being similar to any social networking. The person who receives the person who posts is visible to, or the identity of the person who posts is visible to the mentor. So it's really not anonymous, but that's an excellent point. And then the other question was, did any of those who were mentored express an interest in mentoring others? Yes. Many of the current mentors are individuals who had been mentees in the past. And that's not just in our study, but in the Patient Family Partner Program, the Kidney Foundation of Central Pennsylvania in general. Many actually have become mentors who were mentees at one point. We have another question. Did the online group perhaps surf the internet for additional information on support groups outside of their intervention? They might have. That's a quite likely possibility. We specifically did not ask if they were searching for other information on support groups outside this intervention. So that's another thing to keep in mind, because that could sort of add a dimension to our interpretation. People who were online more frequently were maybe receiving information from support groups outside this intervention. That's quite a valid point and a valid question. What was the median age of the participants? I was wondering if there was a dearth of elderly participants because of having access to a computer. The median age, and I'm going by memory, it was about 58. Might be 1 or 2 years more or less, but it was around 58. So by many standards, pretty young. But we did have up to the age of 78. So there was a range, but the median and the mean age were towards the younger group. And again, that's probably reflective of the fact that our study was biased towards individuals who had computer access and had internet access. The other question is, I'm thinking perhaps incorrectly that the participants who are elderly are not comfortable with using the computers. I don't know. I think we don't really have good data currently about age and computer use and internet use. As an interesting point, my 85-year-old mother is on the computer more than, or actually on her tablet more than any of her children, and she posts more things on the Facebook than we ever do. So I think there has been a shift in the use of online modalities of communication. I would not be surprised that if a study was done and we saw that a significant number of the elderly actually have computer literacy. So in one of the focus groups that we did before we embarked on this whole study, the idea of having an online component to the study came from an older individual, and I was quite surprised. Okay. Did you all consider using an app for the mobile phone? Even my oldest patients utilize their cell phone. Totally agree, and that's our next phase. So our implementation study is going to actually have an app, have a mobile app, because I agree that while computer access might be a challenge, mobile phones are everywhere, and many people use mobile phones. So our next platform is going to have mobile accessibility, mobile phone accessibility. Was it different mentoring dialysis versus pre-dialysis patients? The choice of mentor-mentee was really based more on their practice, which practice they come from, to avoid individuals from different practices becoming the mentee-mentor pair. And I can explain that in a second. But the mentoring itself was not really different. So going back to why the patient-family partner program traditionally has been selective in the mentor-mentee pair coming from the same practice is the fact that there was some concern. There were some concerns early on that on the part of the nephrologist, that if a mentor from another practice mentors their patient might move on to the mentor's practice. So in order to minimize that risk or to avoid it, the practice within the mentorship program has been limited to the procedure within the patient-family partner program has been limited to selecting mentors and mentees from the same practice. So another question is, could you go into more detail about the yoga and meditation interventions? Are those done in-center? We haven't done them, so I can't really answer that. That was one of the polling questions, and some had responded that they have yoga and meditation at their center. We haven't really done any studies on that.
Dr. Ghahramani, thank you so much for answering these questions. A very interesting webinar. I would like to just ask you, in an ideal world, would you like to see online peer mentoring for all new patients? Do you think that most patients are interested and would find it useful? And can you imagine this happening across the ESRD networks?
I don't see why not. I think so online is less intrusive than face-to-face. There's not as much time commitment on the part of the mentor for the mentees, especially those who are on dialysis. They they have time that they can use efficiently for questions that they have, building a relationship with the mentor. So I think, especially with
training enough mentor. Do you think the feasibility of training enough mentors is possible?
That might require efforts more than a patient advocacy organization. It requires significant funding. It requires buy-in from the nephrologists, from their social workers, the patients, the caregivers, to serve as mentors and to be mentored. We've been in a very fortunate situation because overall, number one, we have the Kidney Foundation of Central Pennsylvania with its resources and the fabulous individuals who serve within the Kidney Foundation, and then the region overall is a more or less altruistic, philanthropic region. That might be actually considered one of the limitations of our study, because are you going to be able to have as many volunteers as either as mentors or as trainers for the mentors, because the mentors have to go through 16 hours of training, and do you have sufficient number of professionals who will be able to provide the training? So that actually takes us back to the utility of the online mentoring rather than the face-to-face, because if you're able to provide online teaching in the form of, let's say, webinars to potential mentors, and then have the online platform available, the mobile app, that might actually be much more efficient than each area trying to do their own mentoring. I don't know if I answered your question.
Yes, you did. Thank you. I was thinking in the future and thinking about the feasibility, so that was very helpful. Thank you again. Very important, interesting webinar. In the few minutes that are left, I hope the attendees can fill out the evaluation form. When you exit this webinar, you need to click on a continue button that takes you to an evaluation form. And so to receive your CE credit and also provide us with some valuable information for doing these webinars, we ask you to complete this very short form right now, and I thank you ahead of time for completing it. And we will be in touch with you about future webinars. So again, thank you so much. Have a wonderful day.
Thank you.